to WHO Africa's press briefing. Today, we will be focusing on the impact of the Sudan crisis on health. We have quite a number of experts that are here to provide you with updates, but also to answer some of your questions and address concerns. But first, some housekeeping. You can listen to this briefing in either English or French. To do this, please click on the interpretation icon on the Zoom platform at the bottom right-hand corner of your screen and select your most preferred language. Marie, please, can you explain in French?
Bonjour, vous pouvez suivre la traduction de cette conférence de presse en français en cliquant sur le globe sur le coin en bas à droite de votre écran et en sélectionnant le français.
مرحبا، يمكنكم المتابعة باللغة العربية بالضغط على علامة الكرة الأرضية أسفل يمين الشاشة. شكرا.
Thank you very much, Dina and Marie. And now joining us from Port Sudan is Dr. Dina Abdi, the WHO representative for Sudan. Dr. Abdi, could you please tell us about how the crisis in Sudan is affecting the health of the population? Welcome, Dr. Abdi.
Thank you very much, and thank you really for organizing this very important press conference. As you know, today is 103 days since the eruption of the war on 15 April 2023.
Please, Dr. Abdi, you're muted.
Sorry. I'm really sorry. I was muted. Yeah, this is Dr. Naima Said, Abed, WHO representative in Sudan, speaking with you from Port Sudan. I'm really grateful to the colleagues in Afro region for organizing this very important press conference. And today is 103 days since the eruption of the war on 15 April. And this war definitely, as you have sensed, it has regional implication as well. It's not only affecting Sudan, and it's affecting Sudan, which is a country already with a fragile health system, with poor health indicators when it comes to maternal mortality, infant mortality, and the coverage with the services, and multiple emergencies, including food insecurity, severe acute malnutrition, which we have every third child is almost chronically malnourished, and of course concomitant multiple outbreaks of communicable diseases. When this erupted, actually, since 15 April, actually rapidly deteriorated, further deteriorated the already fragile health system in Sudan. When it comes to the initially there was mostly the casualties, war-related injuries, and so far the number reported, this is the estimated number, of course, 12,115 injuries and 1,100 deaths. Of course, this is very underreporting of the number of casualties, because what we are getting is the information we are getting from the functional health facilities. Service delivery is very much seriously affected by the crisis, because this crisis started in the power center. Crisis started in the capital, and almost 2/3 of the hospital in the affected areas are not functional. Not functional for many reasons. First of all, human resources, healthcare workers, either displaced or, though those remaining, really, we have to mention that they are doing heroic efforts, and we have to really salute them for staying and delivering despite of the life-threatening situation. And still, many of them, they are delivering in the hotspot areas. Security is another issue. Direct attacks on the health facilities As WHO surveillance on attack, we reported verified 54 attacks, but partner reported more than 80 attacks, including injuries and death of the healthcare workers. And of course, in addition to the humanitarian workers. Other factors, operational fund and cash availability, and all this affecting the functionality, fuel, electricity. Since the first week of the crisis, actually, the Central Public Health Lab and the main warehouse for medicine, which is National Medical Supply Fund, became inaccessible. So we have actually, as WHO and other partners, to compensate for that in many ways. And in addition to the government and public facilities, the partner supported facilities reduced almost by 50% because, especially in Darfur states, 5 Darfur states and Kordofan, almost reduced from more than 600 health facilities supported by partners to less than 300. Other major impact of this war is the displacement. Displacement affecting internally more than 25 million people internally displaced and more than 850,000 displaced to the neighboring countries. And really thanks to the governments of the neighboring countries and WHO and the neighboring countries for responding to the health needs of the Sudanese that took safe haven in the neighboring countries. The impact of the public health was really very huge because all immunization activities stopped, vector control activities stopped, and currently we have large measles outbreak with more than 2,000 cases and 30 deaths due to it. Even before the war, the vaccination coverage was not high, so now we have outbreak affecting almost 10 states, but 2 of the states more affected, which are Blue Nile and White Nile states. Vector control activities stopped, and we know that we are already starting the rainy season, and we know that we will have many more cases of malaria, dengue, and Rift Valley fever, which all of these vector-borne diseases are endemic in Sudan. Destruction to the basic infrastructure will have impact on the health as well and public health in general because of the water supply, sanitation, safety of water, and others. So we are expecting actually outbreak of waterborne disease, and we do have an outbreak, or we call it acute watery diarrhea, because we have not been able to confirm the diagnosis in one of the localities of South Kordofan state with more than 300 cases and 7 deaths. So all this will have impact on the health system and on public health in Sudan. We should not forget also the psychological trauma, huge psychological trauma, especially on children and women. So what we have done so far as WHO with other partners and being the coordinator of health response, we actually stayed and delivered throughout all this period. But is our response matching the huge need of the Sudanese people or people in Sudan? Definitely the answer is no. We need to scale up. We need to do more, but there are challenges which we may later on mention that why we could not scale up. First, during the first few days actually of the eruption of the war, we were looking for our own survivors. I myself, I took heaven in a mosque for 7 days, and during my risky self-evacuation, because it was really an experience that I am thinking all the way that I was lucky. I'm a UN staff and I was evacuated. But what about the people who are stayed there still in Khartoum and other areas of, especially now in Darfur, West Darfur? Now there is ethnic dimension to the war. I just can tell you quickly. I left on a compound which was immediately converted into a military base, and then in less than 1 kilometer, I have I have been stopped by the other side of the conflict. So less than 1 kilometer. It's a street war with heavy machines. And meanwhile, I saw 2 bodies on the street. Then I continued my trip with other colleagues to the destination or concentration point. It's less than 4 kilometers. But in that, I have seen 3 hospitals closed while they were delivering services and treating injured people during the first 48 hours of the crisis. So this describes how much, and it was 7 days, but 103 days, definitely the suffering of the people of Sudan, much more than what I have witnessed myself. We have later on, once we settled down, from the first week actually, we started developing the response plan, focusing on hotspot states and the states receiving high concentration of IDPs, focusing mostly on life-saving interventions, trauma and emergency care, surveillance and response to the communicable diseases. And here I would like to mention the cross-border coordination with both actually Egypt and Chad, which was an excellent coordination. I mean, even before the current war, I mean, last year, Khartoum hosted 2 meetings, one on a cross-border meeting, one on Guinea worm, the other one on vaccine-derived poliovirus, or we can say vaccine-derived poliovirus. And this continued during the war, because even during this current complex operating context in Sudan, we have managed to send almost 58 samples to Vaxira in Egypt, and it was from 80 states in Sudan. And we reached the crossing point, and then colleagues from Egypt, they took the sample all the way to Vaxira in Cairo, and we have received the results. And the result indicating that it was well-maintained reverse cold chain, which is really, and now we are in the process of sending 60 more samples. From Chad colleagues, because we do have, I mean, they identified and picked up cases of, we call it acute flaccid paralysis. Cases, I mean, let me say, put it in suspected polio to be clear, and they took samples and they did investigation, and we are waiting for the result of these samples. So there is very close collaboration between the colleagues, technical colleagues on both sides of the borders. We have done actually online courses for almost more than 400 medical healthcare workers in Sudan on treating common illnesses or acute illnesses during a crisis. And this is actually in collaboration with regional office and ECHO. And we have also, to me, if you ask me what was the main input of WHO, was providing more than 200 metric tons of life-saving medicine to 14 states in really a difficult operating environment. Because as I have mentioned earlier, the main warehouse of the government, which is the National Medical Supply Fund, is inaccessible for the government. So we have to somehow compensate for that. And also other partners, I mean, UNICEF, UNFPA, and INGO also, they import medicine, ICRC also. And we have reached 14 states. The state that we are not reaching, we are actually relying on the collaboration with the colleagues in Chad, and we are in the process of bringing medicine through cross-border to both actually West Darfur and South Darfur. So we are exploring all the ways, all the means to deliver services. But more important is really how bringing medicine, bringing supplies, but how to make the facilities functional, to make use of all these medicines and supplies. And this is what we are working now with the partners to select strategically located facilities and provide package of support, including even incentive to the health workers, fuel operational fund, to make them functional. And we are coordinating the response with the other colleagues because, I mean, WHO is the health cluster coordinator. So what next? What next for WHO? What we need really is more flexible funding, because now currently the humanitarian response plan and the WHO appeal is less than 20% funded. And we need more fund actually to be effectively responding to the need of Sudanese, because as I mentioned earlier, frankly, that the response until today is not matching the needs of the Sudanese people. We need access to reach the facilities and to reach the states and to be more effective in responding to the crisis. So we need really peace to be able to deliver. And we need also to continue supporting the service delivery through selected facilities, especially dialysis, chronic diseases, diabetic centers, cancer centers, because now these interventions are life-saving, and the government doesn't have really that fund or to do all that. And we continue building the capacity and the system resilience, supporting the essential public health functions, especially immunizations and vector control, because these are the two main public health risks now. We are measles outbreak in a country with very high prevalence of acute severe malnutrition. These are a deadly combination, actually. And we have high mortality from measles outbreak, and really malaria is coming also. Malaria, dengue fever, and Rift Valley fever, and all other diseases that are transmitted by vector, especially mosquito. I will stop here. Thank you very much.
Thank you very much, Dr. Abid, for that update from Sudan. Dr. Abid is a WHO representative to Sudan. And now we are turning to WHO representative in charge, Dr. Jim Bosco. Can you please tell us how the health of the people that fled Sudan is evolving, those ones that fled to Chad? Dr. Jim Bosco, please.
Oui, bonjour à tout le monde, bon après-midi. Moi, je m'appelle Jean Bosco Ndiokoué, je suis le président. Est-ce que vous m'entendez, s'il vous plaît? C'est bon?
Super. Go ahead, please.
Thank you. Merci beaucoup. Moi, je m'appelle Dr. Jean Bosco Ndiokoué, je suis le représentant de l'OMS Tchad depuis bientôt 7 ans. Je commence à comprendre un tout petit peu le pays. Alors, la situation ici, je vais vous dire, c'est quelque chose que je n'avais jamais vu en 22 ans de carrière à l'OMS. Ce qui est impressionnant, c'est vraiment le nombre de blessés de guerre que nous avons reçus en une période très courte de temps. Je vais vous donner un exemple. Le 14 juin, c'est là que les blessés de guerre ont commencé à affluer au Tchad, juste quand les troubles Darfour ont commencé. On avait exactement 32 blessés de guerre. Le 16, nous étions à plus de 1000 blessés de guerre. Et au moment où je vous parle, nous sommes à 2357 blessés de guerre. Donc ça, c'est vraiment la première crise à laquelle nous devrions faire face très rapidement. Et je voudrais ici remercier les collègues du bureau régional qui nous ont appuyés très rapidement en nous approvisionnant en intrants divers, en antipallidique, en kit choléra, en kit nutritionnel pour traiter la malnutrition aiguë sévère et ses complications, mais surtout en nous envoyant, nous avons pour le moment une trentaine de tonnes de matériel de chirurgie de guerre et de chirurgie générale. Ça, c'est une très bonne chose. Le deuxième problème sanitaire auquel nous faisons face aujourd'hui, c'est les problèmes de malnutrition aiguë sévère dans les camps de déplacés, dans les camps de réfugiés. Nous avons pour le moment un peu plus de 4000 enfants qui souffrent de malnutrition aiguë sévère, avec une mortalité quand même relativement élevée. Pour le moment, sur 250 enfants hospitalisés, il y a eu déjà 65 morts. En fait, ces malnutritions aiguës sévères, vous savez, ça entraîne une dépression immunitaire. Et si cette dépression immunitaire se greffe des maladies comme la rougeole, qui est vraiment très meurtrière en cas de malnutrition aiguë sévère, mais aussi le paludisme, les gastro-entérites aiguës, mais aussi les infections respiratoires aiguës. Ça, c'est vraiment le troisième problème, évidemment, auquel nous faisons face en termes de santé, c'est le manque de place pour les enfants qui souffrent de malnutrition aiguë sévère. Au moment où je vous parlais pour le moment, par exemple, nous avons eu les appels de MSF France qui nous demandent 150 lits, qui nous demandent plus de 1000 doses d'antibiotiques. Heureusement, les doses d'antibiotiques, nous les avons, qui nous demandent aussi des tentes médicalisées. Nous avons quelques tentes médicalisées, mais les 150 lits, on est en train de les chercher. Voilà ce que je peux dire pour le moment. Et bien sûr, ce que nous faisons ici, en tant qu'OMS, c'est la coordination des autres partenaires, des partenaires du secteur de la santé, en collaboration avec le ministère de la Santé publique, parce que, comme vous le savez, c'est une crise où plusieurs partenaires interviennent. Il ne faut pas qu'ils interviennent dans le désordre, il faut qu'il y ait une coordination. C'est ce que nous essayons de faire pour le moment avec succès en collaboration avec le ministère de la Santé. Je vous remercie.
Thank you very much, Dr. Jimbosco, for that update from Chad. Now we move to the regional incident manager for this response, Magdalene Arma. Magdalene, can you please tell us what is happening in other countries receiving the refugees?
Thank you, Mary. Over 760,000 have been displaced into 4 of the Africa region countries, led by Chad at close to 46%, followed by Ethiopia, South Sudan, and Central African Republic. Many of these are arriving with trauma, including gunshot wounds, long delayed illnesses, and other effects of infectious outbreaks. Now they are being displaced into systems that are already fragile and unable to absorb the surge. The influx has also raised potential for infectious diseases, and these have included measles, malaria, cholera, and yellow fever. We're also seeing high cases of malnutrition and also actually beginning to record high levels of mental health coming into the various countries. The human resources in these countries are already stretched, and they have become even more inadequate because of the large responses in the various regions. Our report tells us that Chad alone needs close to 2,500 critical workforce to respond to what is happening in Chad. South Sudan equally overstretched along the borders where they're receiving the influx. These are countries that already have limited capacities for public health response, and they're having to share the resources with the influx that are coming in. WHO very quickly has worked with the 4 countries to ensure that the moving population receive the needed healthcare as they arrive in the various countries. To date, out of WHO's internal funds, $2.4 million has been distributed to the 4 countries. There's been a dedicated health facility of at least 300 across the 4 different countries to ensure that health facilities are accessible and used by the moving population. 90 emergency critical health resources have been deployed to the various response sites in the different countries, include medical doctors, surgeons, epidemiologists, public health officers, nutritionists, and mental health specialists. Capacities in excess of 1,000 have been developed across the 4 countries to ensure that surveillance systems are wholesome, to ensure that consultations are happening. And by the way, to date, we have recorded in excess of 150,000 consultations across the 4 countries. A total of 60 tons of supplies have gone out to support the 4 countries, almost 40 tons to Chad alone, the rest to be divided amongst the other countries. What currently concerns us is that as the displacement continues into the countries, we're beginning to see severe acute malnutrition in under 5s. That is complicated by malaria and other diseases. We're seeing an increase in infectious diseases outbreaks. We're seeing cholera, we're seeing measles. It actually begins to concern us in countries that are already challenged. We're also seeing a lot of under fives that are crossing the borders. It really means that they're very fragile in their own right. And also we need to ensure that things like routine immunization is not disrupted for those under fives that are moving. And then finally, the trauma cases for which my colleague in Chad has already alluded to. What actually needs to be done? I think what is clear is that the WHO Africa region has unfortunately received 65% of the population that has been displaced out of Sudan. While these 4 countries have mounted unprecedented health response, we need to also remember that these countries traditionally hosts a combined vulnerable population in excess of 28.2 million. They have a health response plan at 501 million, which is 30% underfunded. You add to that the close to 500 that has also influxed into the countries with a response plan of 29 million, that is only 2.4 million funded. WHO wants to ensure that we're able to continue and sustain the response that has started for these countries. Our next steps include targeting interventions for the following: establishing cross-border operations to ensure that all vulnerable populations are reached with healthcare. We want to increase access to healthcare services by expanding the setup of the emergency teams that are in the various border regions. We want to ensure that vaccination campaigns can happen to mitigate further outbreaks. We want to ensure that disease surveillance goes down to the communities in all the 4 countries. And finally, we want to ensure that to mount a fine-tuned, equitable response, that operational support and logistics have the funds they need to deliver health commodities, especially to the difficult to access response location. The WHO Regional Response Plan of USD 29 million, which is currently funded under 3 million, can be further supported to ensure that all critical response elements are made available for the health operations. Thank you, Dr. Mary.
Thank you very much for that update, Incident Manager for the crisis in Sudan. And now we are moving to journalists. Since you have heard from all our panelists, it is your time to ask your questions. To do this, please use the Q&A function on the Zoom platform. Tell us your name and the name of the media organizations you represent. If you would like to ask your question live, you can raise your hands, but please provide some details in the Q&A. And we have additional experts on hand to answer your questions. This includes Dr. Nima Al-Gassir, the WHO representative to Egypt, Dr. Lamini, the acting WHO representative in Ethiopia, Dr. Patrick Otim, Health Emergency Officer for Acute Events here at the regional office, and Dr. Charles Njuguna, the Regional Advisor for Readiness Strengthening. So now I'm going to start with the written questions. Again, send us your questions in the Q&A function, or you raise your hand if you want to ask your question live. So the first question is coming from Halima Kigandi from the World Radio Program. Halima is asking, her first question is, how is the conflict in Sudan impacting women's and girls' health? Can you speak of sexual violence and maternal health in particular? Then the second one is specific to the can they say or speak to pregnant refugees losing babies as you cross over, and then the victims of rape, are they arriving pregnant at the border? So I will start with the WHO, acting WHO representative in Ethiopia, Dr. Lamini, to address the first part of the question, and then the WHO representative to Chad to address the second part. Dr. Lamini, please.
Thank you very much, and good afternoon to all those on this call. I'll be speaking about the effects in Ethiopia, and then touch on the on pregnant women and GBV. So our main point of entry is Metema, and as of July the 23rd this year, we've had a total of 68,221 individuals who have crossed the border. And of this group, 29,046 are female, and just below 8,000 are children under the age of 5. And then half of the people that are crossing are actually Ethiopians, 31% are Sudanese, and 12.5% are Eritreans. So far, 18,698 individuals have received primary health care services. So when we speak primary health care services, antenatal care is part of that package of PHC services that we provide. And then during this last reporting week, there were 2,508 people that actually received services. And then 245 individuals were actually referred to hospitals. So unfortunately, amongst these 245, I don't have the breakdown of how many were pregnancy-related referrals. But most of them, the primary health care services, are able to take care of their antenatal and maternity care needs. So as far as us, the WHO office is doing here, we have provided financial support to the Federal Ministry of Health to deploy an emergency medical team. And again, within that package of care, we're also giving the comprehensive care for maternity services. WHO has provided logistical supplies, including 3 tents, to set up a temporary shelter for screening basic primary health care. And we are actually supporting the Regional Public Health Institute, and we have an entity called the Refugees and Returnees Services, which is one of the key entities here in Ethiopia. And we are deploying a medical team to provide essential primary health care for diseases, and we are conducting surveillance as well. At the border, we have technical officers that are providing support for partner coordination for mental health and psychosocial support. But we combine this with risk communication and community engagement. And with that, we actually supply, we provide medical supplies, especially for the mental health aspect, because some of the people we're dealing with actually need medication. Emergency medical supplies have been distributed to medical teams, to health facilities, and we also give supplies to health partners. And so far, the supplies we have out there will cover a total of 150,000 beneficiaries. Gender-based violence is another area I think that we need to touch on, and it will also contribute to the mental health needs that we're seeing. So we also have assigned officers that will specialize in gender-based violence and provide the services thereof. We also thus far have one clinical psychologist that's actually working at the border. We're also working with UNICEF and IOM, both of which have dedicated staff for gender-based violence and for mental health and psychosocial support. And then at the UNHCR Transit Shelter, the service is also provided by UNHCR and the entity I told you about, which is the Refugee and Returnee Services. And other partners have also dispatched GBV and MHPSS experts. So it's a lot of partners out there doing different things. So the coordination is really key. And who's providing that coordination? That's WHO. And then lastly, so that we don't forget that just women, children, and everybody there is also at risk of getting cholera. So we've also put medical supplies for cholera preparedness and response, and we've pre-positioned these at the zonal level. We're also trying to get our funds together to actually deploy what we call mobile health and nutrition teams who go out and take the services to the people. And part of the makeup of a mobile health and nutrition team is a midwife, nurse, clinician, and someone who looks at mental health. So I'll stop with that. Back to you, Dr. Mary.
Thank you very much, Dr. Lamini. Indeed, the health of women and children is very, very important in this crisis. Thank you so much. So, Dr. Jimbosco, you were supposed to answer the second part of the question, which is to speak to the reports that pregnant women crossing the borders are losing their babies, and also that victims of rape are crossing borders pregnant. Dr. Jimbosco, please.
Merci beaucoup. Je voudrais rappeler que le Tchad paie le plus lourd tribut de cette crise soudanaise avec 51% de réfugiés qui viennent ici au Tchad sur un rythme effréné depuis le début de la crise. La deuxième chose que je voulais dire, c'est que les enfants, les femmes et les enfants payent un très lourd tribut aussi à cette crise. Tenez, par exemple, parmi les réfugiés, les 329 000 réfugiés, nous avons à peu près 21% d'enfants de moins de 5 ans, ce qui est énorme. Parmi les retournés, parce qu'il y avait des Tchadiens qui étaient au Soudan, nous avons sur 48 000 retournés, nous avons 93% de femmes et d'enfants. En termes de maladies, par exemple, sur les blessés de guerre parmi les enfants de moins de 5 ans, nous avons à peu près 11% de blessés de guerre, des enfants de moins de 5 ans, et 32% de ces blessés de guerre, tout type de blessures, ce sont des femmes. En ce qui concerne les femmes qui meurent en cours de route, on n'a pas vraiment ce chiffre-là. Par contre, ce que je peux vous donner comme données, c'est la mortalité maternelle dans les sites. Sur à peu près 13 000 femmes enceintes, c'est 13 000 femmes enceintes que nous avons dans les sites, essentiellement le site d'Adré qui abrite le plus grand nombre de réfugiés. Nous avons à peu près 7% de femmes qui ont perdu la vie en termes de mortalité maternelle. Et puis, bien sûr, je l'ai dit déjà, pour la malnutrition aiguë sévère, ce sont les enfants essentiellement de moins de 5 ans qui en souffrent et qui meurent. Et nous avons déjà 65 enfants de moins de 5 ans qui sont morts de malnutrition aiguë sévère sur à peu près 250 hospitalisés. C'est vraiment vous dire que cette crise frappe de plein fouet la santé de mère des enfants. Merci beaucoup.
Thank you very much, Dr. Jimbosco. And this next question is coming to you, Dr. Abid, the WHO representative for Sudan. The question is from Simon Marks from Bloomberg. He's asking, has the WHO documented specific targeting of health centers and water pumps based on ethnicity of people being treated or served? If so, how many, where, and what? Dr. Abi?
Yeah, thank you. Thank you very much for this question. I mean, WHO verified 54 attacks on health facilities, and these are targeted, I mean, including either health facilities or health worker or ambulances or premises, and actually by all those who are in war. But is it ethnicity based? I do not have answer for this question, because usually it is in the area of active conflict. And the active conflict in Khartoum is different from the active conflict in West Darfur, where there is in West Darfur ethnicity element to the conflict. So it's actually it's part of the overall situation in the country, and many of the quite good number of the health facilities being forcibly evacuated to be used as, or to be militarized and to be used as military bases. So this is happening in Sudan. So far, we documented 54 in the system, which is surveillance on attack on health. Our regional director, our Tedros, the DG, I mean, they condemned these attacks in the strongest term. We have reached as much as possible to the authorities and protesting about these attacks on facilities. But it's actually ongoing. I mean, the most recent one is in Khartoum, it's just less than a week ago, on MSF colleagues. I mean, they were bringing medication and supply to the hospital in South Khartoum. We call it Turkish hospital, and they were being actually, I mean, some of them beaten and some of them really humiliated while on their way to the hospital. So it's still ongoing, which is very unfortunate. And this is one of the reasons why health services in Sudan really being affected, direct attack on the health worker and health facilities and ambulances as well. Thank you.
Thank you very much for that response, Dr. Abi. And the next question is coming from Sarah Javin from Debex. Can you talk about the status of health workforce in countries like Chad that have received refugees? Has there been an influx in health workers sent in, and where are they coming from? What sort of workforce gaps are there? So I will start with Dr. Jimbosco, since she's referring to Chad, and also ask Dr. Lamini to complement from Ethiopia. Dr. Jimbosco, please.
Merci beaucoup. C'est une question essentielle dans un pays comme le Tchad. Vous savez, la plupart de nos pays ont des systèmes de santé faibles. Le Tchad fait partie des pays avec un système de santé très faible. Et la plus grande faiblesse de ce pays, c'est justement le manque de ressources humaines en santé. D'après les études que nous avons faites depuis 5-6 ans, ce pays, aujourd'hui, a un gap de 37 000 agents de santé, toutes catégories confondues. Un gap à recouvrir. C'est énorme. Donc, quand vous dites qu'il y a des personnels de santé, bien sûr, le ministère de la Santé a dépêché des personnels de santé, le peu de personnels de santé qu'il a au niveau des provinces de l'Est, essentiellement à Dal-Wadaï, qui reçoit 78% de ces réfugiés du Soudan. Nous avons aussi, bien sûr, l'OMS a une équipe de chirurgiens à Béché. Et cette équipe de chirurgiens opère essentiellement sur des patients, sur des blessés de guerre que les partenaires comme MSF, France et le CICR n'arrivent pas à opérer à partir de Hadré parce qu'ils n'ont pas tout le matériel. Donc, ces blessés de guerre sont référés à Béché et c'est l'équipe de l'OMS avec une équipe de CICR qui opère sur ces blessés-là. Deuxième chose, nous avons d'autres partenaires sur le terrain. Nous avons un partenaire avec lequel on vient de faire des contrats. C'est le partenaire qui s'appelle Alima, qui va intervenir sur les soins de santé primaires, qui va aussi intervenir à aider les autres partenaires dans l'évacuation des blessés de guerre qu'on n'arrive pas à opérer à Adré. Nous avons un troisième partenaire qui est en train de venir et qui vraiment aide beaucoup parce que leur cargo d'ailleurs arrive tout à l'heure à 15 heures. Je serai à l'aéroport. Ils amènent des intrants nutritionnels, des antipalydiques, des kits choléra, mais aussi du matériel de chirurgie. Et surtout, ce dont nous avons besoin le plus, ce sont des tentes médicalisées. Ils vont amener aussi une quantité importante de tentes médicalisées dont Adré, par exemple, a besoin. Donc, en termes de ressources humaines, bien sûr, avec l'afflux des réfugiés, les manques sont énormes en termes de ressources humaines. Là, par exemple, j'étais sur le terrain avant-hier et MSF disait qu'il essaie de recruter très difficilement à peu près 300 personnels de santé, toutes catégories confondues, pour s'occuper essentiellement des enfants parce que les enfants malnutris aiguë sévère affluent de façon massive. Nous avons nous-mêmes, bien sûr, une équipe très limitée de l'OMS, une trentaine de personnes, dont un gynécologue et un pédiatre qui sont sur le terrain en train d'appuyer les autres partenaires à donner des soins à ces enfants et à ces blessés de guerre. Voilà ce que je peux dire pour le moment. Donc, le plus grand problème vraiment ici au Tchad, c'est le manque de ressources humaines qualifiées. Et les provinces de l'Est, essentiellement, ont besoin de 2500 agents de santé. Nous pouvons les trouver sur place. Nous les trouvons sur place parce que la plupart sont au chômage. Quand on les trouve sur place, il faut les former et puis alors les déployer. Mais pour le moment, nous sommes en train d'appuyer le ministère de la Santé publique à mobiliser ce personnel-là et à le déployer au niveau des provinces de l'Est. C'est beaucoup d'argent. On est en train de négociation avec des partenaires comme le Fonds mondial et on espère que nous allons y arriver et puis pouvoir déployer ce monde-là. Merci beaucoup.
Thank you very much, Dr. Jimbosco. Dr. Lamini from Ethiopia, what is the status of the health workforce there as it relates to the response to these emergencies to the refugees we have received?
Hey, thanks. Yes, this is, of course, an extra burden that has come to us. In addition to the extra workload on our established healthcare workers, we also have an overstretching of community health facilities with increased need for medical supplies. There's overcrowding. And then the other challenge we're facing is that we have a deficit in the overall water coverage, supply of potable water. So there's a drop in this safe water from 16% to 8% in the urban areas. And in one of our most affected districts, it's dropped from 43% to 35%. So, of course, once we have this challenge with safe drinking water, the risk for diseases goes high. So in terms of a need for the human resources themselves, what happened is as soon as we had this influx, our emergency medical team, so the Ethiopia Ministry of Health actually has an active emergency medical team. So they were actually out in Turkey at the time, attending to the earthquake response. So they came back and they were immediately deployed to the border area. And of course, all of us then came in and helped putting up the tents and making sure the supplies were there. But this EMT needs to be maintained. Of course, we have to support that aspect and also make sure that they have the supplies. And we even have to set up another EMT in another region that's also being affected by the influx. So there's that critical need. So that's also now as WHO, we have deployed 5 officers again to Metema. Some of them are for cluster coordination. Some of them have to do the surveillance. And of course, I've already mentioned the mental health and psychosocial support, but we also need officers to look at operations, supplies, and logistics. So it's not just the clinical services that we're talking about, but all these other persons that we need. So we have officers from the central and our sub-national offices, that's WHO, also been repurposed to go and support over there. And then we've been giving the different types of medical supply kits. So in WHO, we work with kits. So if you need a breakdown, we can tell you how much of the interagency emergency health kits we've sent, non-communicable disease kits, because some of the people who are crossing have got diabetes, high blood pressure, mental health programs. Reproductive health kits is another big type of kit that we have to put there, and that's for maternity care services and our prenatal care. Trauma and emergency surgical kits, we also have to send those. And then, like I said before, we also have to pre-position our cholera RDT kits. Then we're also mobilizing, we're also getting more mobile health and nutrition teams. And like I said, these are the teams that go out to the communities, go out to the refugee camps and supply the services so that the healthcare centers are not overwhelmed. Thank you. Back to you.
Thank you very much, Dr. Lamini. And this next question is coming to you, Dr. Nima, the WHO representative to Egypt. The question is from Hazina Firi with the Zambia Media Network Against Tobacco and Metro FM Radio. She's asking what is being done to make sure that as the people are displaced, their health status is quickly taken care of. You could also comment on the health workforce in Egypt as it relates to responding to the refugees you have received. Dr. Nima, please.
Can you hear me? Good evening. Good afternoon.
Yes, we can hear you. Go ahead. Good afternoon.
Good afternoon. Thank you very much for this opportunity. And I would like to echo my Sudan, representative of Ethiopia and Chad, on the necessities that we work all, whether it's technical or support or the logistics. As the border of Aswan, I don't know whether Egypt is one of the largest Sudanese influx come, because Egypt and Sudan have been working together in different ways, like a brother and sister. At the border, what happened in terms of the human resources, we do have immediately established, WHO was the first organization to be on the ground with hand in hand with Ministry of Health surveillance team under health security and public health threats. But more importantly, which is a very unique to this experience, is that we immediately addressed the psychosocial mental health, including addressing the gender-based violence. By the third day, 80 volunteers, nurses, physicians were oriented on the humanitarian settings when it comes to the gender-based violence, and at the same time when it comes to psychosocial. By the third day, there was the Ministry of Health at Aswan assigned us a location to deliver and gave safe services for the ones who are going through stress and the services. The other thing that happened, talking about the healthcare provider, with the mental health unit or arm of the Ministry of Health, immediately the psychosocial ones who have been trained from the center of Cairo were actually educated immediately on how to address on humanitarian. So many people did not have that experience, but WHO immediately working and calling also upon our sister agencies. What happened, we were addressing four elements: public health security at the border, making sure that everyone is safe, whether it is the refugees coming or not, but at the same time, making sure that they are treated well, because the government of Egypt set up the borders immediately when the influx was very high. How can we make sure that they have access to safe water, safe food, but at the same time, safe shelter? Not one thing that many journalists and many of our colleagues within the humanitarian settings do not know, and they get surprised when they get to Aswan, because they will see everything is normal, but nobody asking why. There are no camps no camps. Egypt is one of the few countries in the world that does not set up camps. So that's why the humanitarian colleagues, when they are coming, they are looking for camps. They are looking for people who are on top of each other. We don't have that. There are no detention centers. There are no waiting. The first few days they were waiting because of the security clearances on the other side of the border. So what happened? There was a negotiation with the UN and the government of Egypt. How can we reach the other border? I was privileged to be able to go and see by the third, fourth day on site what is happening at the border. So it is not recalling from the paperwork in front of me, but actually being present. 3 observations. There was large influx of women and children who were really traumatized. And this happens, especially if they have gone from a long place. The second, that there were families had hesitancy to give the polio vaccination for free for their children and the children vaccination. They were hesitant because they kept saying, we have given them, we cannot. And this is for journalists is very important. Polio vaccinations, children vaccinations, it's protecting the children of Sudan, of Egypt, and other refugees. The third observation that we observed, that we needed to be really looking on actually how can we reach this population. Why? Because once they were taken by the bus to the center of the Aswan in Aswan, there was an issue on how can we continue giving them the service. So in our interaction, immediately we looked, by the third day, we knew what are the hospitals, health services, healthcare workforce, and also supported the Ministry of Health surveillance team to be at the border, at the point of entry. This is with Qustul. With Arqeen, which is another influx people coming, we have tried to really position the same, but our observation, majority are coming from one point of entry, which is closer to Halfa. A part of the services that we provided, given that I had served before my current successor, Dr. Naama, who has been really handling this, I was there as a representative for 5.5 years in Sudan. So that has also witnessed the revolution. One of the critical, burden of disease, aside from public health threats, are non-communicable diseases. And we have seen majority of the Sudanese coming, not only the regular, the ones who are coming with the mental issues and trauma, but also with the non-communicable diseases such as heart problems, diabetes, hypertension, cancer, and renal problem. So by the way, within the first 3 weeks, we had 110 patients who needed dialysis. This is not in our radar as humanitarian. We had many people who needed medicine to continuity for their hypertension. So WHO was the first to deliver 30 metric tons by the first week was there, and tools for protective equipment for healthcare workers frontline, because that was a concern. There was a misperception that everybody's coming with the virus, and we had to handle that misperception. That's very critical as WHO as humanitarian setup. The other thing, immediately within a month, we delivered 10 tons for essential medicines. I want to say to the media, what does it mean in your language? 40,000 patients, not people, patients receives care for non-communicable diseases if they need it, whether it is diabetes, hypertension, heart problems, cancer, and renal disease. So, respiratory. These were some of the things, but also what we did, mapped quickly on what are the available services. We want to acknowledge the non-governmental organizations, both local and international. We want to, as WHO, to acknowledge the donors who really came and tried to put a seed fund. More importantly, our continuous alert on the gender-based violence and on the action, what we call the prevention of sexual reproductive health within the entities who are working us and abuse. What we did, all our partners have been educated, trained. It's almost every week. Last week was with WHO, IOM, UNHCR, UNFPA, we did it. So we are bringing as an organization a package, and that is a change for everyone who is handling the humanitarian, who have not handled in the last 10 years. Under public health security, and that is my last line, I hope I've answered the question. that aside from emergency humanitarian, we are looking in terms of water sanitation was a key at the border, heat coming. So that's another thing that's continuously happening and working with the UNICEF hand in hand. The final is the support, and we want to give credit to the Sudan WHO in actually handling the polio samples to be brought to Egypt to be tested, so we can assure everyone that still work is happening with all the difficulties under health security to make sure that we are not going to have eruption of the polio cases in the sewage system. This is a very public health security for the journalists. That means we are still, as the WHO, very, very diligent. It is not visible to you. It is not blood. It is not people with injury. It is actually soldiers who are invisible, public health, doing the job on the ground and making sure our samples are delivered from Sudan to the heart of Cairo. And Dr. Naama can tell you that all the results have shown that everybody has taken care from every steps. And this brings diligence of our public health officers that rarely we talk about them. My plea to the journalists, please, please, please check, validate. We are all here as representative, as WHO, to give you a response. And we will be honest, truthful. We are not hiding anything, because public health security, we cannot hide. It will come out. It will be out, and we cannot control viruses or bacteria. Our position is, in Egypt, they go into integrated in the population. Nobody, and then we need to find how. And what we did, we established within the services, including for some cases, few cases that were subjected for sexual harassment, were given the PIP kit if they need it. This is Ministry of Health validated. But also we have given for pregnancy, there has been access. Still, a lot of work needs to be done because it's a continuous, less influx is now less, but we are expecting maybe the dynamics will change. So the readiness is continuing. And we are really thankful to the government of Egypt for trusting us and allowing us to work and to have our team at the border continuing and not just going whenever there is a crisis. We have established a system is supporting both, and thank you for this.
Thank you. Thank you very much, Dr. Nima. Regarding the service provision for those that cross border, how we ensure that they quickly receive services. Magdalene, do you want to comment from the regional perspectives as well?
Yes, thank you, Mary. Indeed, emergency response actions are effectively delivered with seasoned partnerships. And that's what WHO does. We coordinate them. So working with the UN family and partners, we ensure that the points of entries are marked and tracked. This gives us access to numbers and presence, and then allows us within 48 hours to assess the needs of the populations that are coming in. Please note, though, that half the time, the displacement routes are places that are difficult to access, but we do try to ensure that in 48 hours, we're able to assess their needs. We also work with our preparedness wing that is within WHO to ensure that we are able to make health facilities accessible. For instance, we would upgrade those that are non-functional. We will position commodities to ensure that the population are able to use that. We will also very quickly build capacities that are needed for the type of response that is required. For instance, within 72 hours, we made sure that we deployed so that surgeons are able to take care of the trauma cases going into Chad. Within 48 hours, we ensure that suspected VHF in South Sudan and in other parts of Ethiopia were attended to and samples were collected. We also make sure that surveillance, which is indeed a very critical part of displacement of host people, is stepped up so that we're able to screen the numbers of people who are coming in to try and mitigate an outbreak. So these are some of the things that we do to ensure that the right healthcare service provision is made available at the different borders. Thank you.
Thank you very much, Magdalene. And the next question is coming to you, Charles. This question is from John Musenze from New Vision. As the World Health Organization, are we ready for another pandemic like COVID? What are the priorities for the next 3 to 5 years? Charles, please.
Thank you very much, Dr. Mary. As WHO, we continue to be ready for the next pandemic, but I think more importantly is to acknowledge that it's our member states that directly respond to emergencies at country level. And I think this is where the rubber meets the road. We are aware that the Director General, Dr. Tedros, did declare that COVID-19 is an established and ongoing health issue and no longer constitute a public health emergency of international concern. But however, we need to also know that the virus continues to circulate, and it is going to be with us in the foreseeable future. So what we need is to continue being ready to deal with any threat that may come. For now, in terms of COVID, countries, we have supported them to transition the COVID management into the health system strengthening so that we can have better resilient systems. In terms of our WHO priorities, we have already outlined 5 key priorities for the next 2 years. And we have developed a document to guide on how we are going to support countries in the next 2 years. One of the key priorities is about emergency coordination, ensuring that we have better coordination structures, but also ensuring we have flexible financing. And this is something also, Dr. Abid, you mentioned about, that really we need flexible financing when it comes to emergencies, and also continue monitoring. The second important key area is about collaborative surveillance, ensuring that we have surveillance systems that are functional. And for diseases like COVID, is ensuring that the lab surveillance system is working efficiently, ensuring that we have the genomic surveillance going on to be able to track the circulation of the variants that we have. The third important point is about community protection. We know very well that public health emergencies start in communities and they also end in communities. So there is need to ensure that we have better community protection in terms of engaging our communities, in terms of addressing issues of border health and issues of mass gathering. The fourth important point here is also ensuring we have safe and scalable care, whereby patients can be given proper clinical care and they can have drugs that can help them to recover, and also ensuring that we have systems that are working for infection prevention and control. And we should not also forget, we need to continue ensuring that we have essential health services that are going on during the times of emergencies. That is when we can talk about resilience, when our healthcare systems can be able to withstand the shocks of emergencies. And lastly, very critical is that we need to have access to what we call countermeasures or tools that will help us to fight pandemics. And this includes the vaccines, this includes supplies and drugs. All these processes require a whole government approach, a whole society approach. And also, as I wind up, just to mention that we have now a World Bank facility that has come in place to support pandemic preparedness, and the first batch of countries have already been named that will be provided support to ensure that they put better resilient systems and that we are ready for any other future public health emergency like the COVID that we had. Thank you. Over to you.
Thank you very much. Now we have come to beginning to round up on the presser for today. So we will turn to our panelists. You have 1 minute each. Give us your final thoughts. I'm going to start with Dr. Abid, and then Dr. Jim Bosco, then Magdalene. Dr. Abid, your final thoughts, please.
Thank you very much. And I think media have very pivotal role in highlighting the situation in Sudan. And we need to scale up. And to scale up, we need more funding, flexible funding, actually, and more operation and more agility to respond to the need of the people of Sudan. Thank you very much for this opportunity.
Dr. Jim Bosco, your final thoughts?
Merci beaucoup. Moi, ce que je dirais simplement, c'est que nous devons tenir bon. La crise soudanaise n'est pas finie. Les problèmes de santé vont toujours continuer à s'opposer. Nous devons continuer à bien nous coordonner, à nous entraider, à échanger les informations comme nous le faisons très bien avec le Soudan. Et nous apprécions vraiment les appuis que nous recevons aussi du bureau régional. Et puis, continuer de mobiliser le plus de ressources financières, mais aussi humaines, c'est-à-dire les partenaires qui peuvent aider à intervenir aussi sur le terrain. Voilà ce que je peux dire pour le moment. Merci beaucoup.
Thank you very much. And to you, Magdalene.
Thank you, and Mary. Well, displaced populations are vulnerable from the epicenter of trauma, and they require a whole of root approach. The health services concerning mental health to clinical health needs have largely been mounted by WHO, and they are very central to the existence of many of the population. As we continue to support acute health needs, we also have to understand that while they are critical and require unprecedented interventions, we also have to make sure that the services that we are providing are finite, equitable, and that the population are able to enjoy good health, which is a right for them as they're moving. We therefore need to have our partners come to back and support us to ensure that this is done for the common good of the people who are moving. Thank you.
Thank you very much. And with that, we have come to the end of the press briefing for today. Thanks to all our panelists, thanks to all the experts that have spoken, and thanks to you, the journalists. Thank you for continuing to provide the population the right information. So thank you, everyone, and have a nice day.